Okay, good evening, everybody. It's our pleasure today to have again our continuity of education under the umbrella of Gulf Interventional Society. We have a very good presentation and webinar today. We'll go over the last ACC trials that related to interventional cardiology. I thank you all for being with us, and thanks for our speaker and panelist. Today we'll have Dr. David Kansari, well-known interventional cardiologist to all of us. He is the Chief Scientific Officer, Chief of Interventional Department and Interventional Research Activity in Piedmont Healthcare in the United States. Welcome, David, to us. Also, we'll have our panelist, Dr. Mohammed Kurdi, interventional cardiologist and president of SASIS in Saudi Arabia, Dr. Abdullah Shihab, Vice President of GIS Interventional Cardiology from United Arab Emirates, and Dr. Hani Ragi, well-known in Egypt. He's the ex-chief of the cardiology department in National Heart Institute, and a very high volume interventional cardiologist, big interventional cardiology in education, and always have a good collaboration with our area. Thanks for being with us. Thanks for our audience. We already have more than 550 registered. Without any further ado, I will allow Dr. Kansari to start his presentation, then we'll take it from there. David?
Thanks for having me again. And I'm going to share my screen, and please just let me know that you see my slides just to begin with. Perfect.
Okay.
Again, this is a welcomed opportunity to be with all of you, and so many of you too, at an unprecedented time worldwide with the COVID illness. I'm very grateful to be able to share with you an overview of the American College of Cardiology late-breaking trials and featured research from that program that, as many of you know, was a virtual program because of the issues related to the COVID virus. Like many meetings, and the one we're out having here this evening was one that was presented by virtual scientific sessions. We'll begin with a variety of topics related to interventional cardiology over the next 30 minutes, from studies dedicated towards new thoughts and strategies with antiplatelet therapy to complex coronary intervention, specifically left main disease, but begin with hypertension, and specifically with device-based therapies for hypertension. Hypertension itself is the leading cause of death and disability worldwide. In the United States alone, it affects over 29 million individuals who have persistent uncontrolled hypertension despite the prescription of antihypertensive therapy. In fact, in the United States, as just one example, more than half of the individuals who are diagnosed with hypertension have blood pressure that exceeds treatment recommendations by societal guidelines. To date, the broadest experience with renal denervation therapy as the most studied device therapy for the treatment of hypertension stems from the Medtronic-sponsored Spiral and earlier Simplicity Flex program. This has been a dedicated program over several years now, evaluating radiofrequency energy delivery to ablate the renal efferent and afferent nerves, and has been studied in both single-arm observational studies, unblinded randomized trials, and now a succession of sham-controlled randomized clinical trials that have been recently completed as a pivotal study, that continue to be ongoing as complementary and companion studies, and further is a program that is pursuing other unmet needs, such as understanding patient preference, how we do the procedure, and perhaps other indications beyond hypertension itself. Recall that renal denervation therapy using the spiral catheter is one in which the catheter is delivered over a guide wire into the renal arteries, and specifically into the distal branch architecture as well as the main renal artery. The catheter itself assumes a helical spiral configuration that allows treatment of a single or up to 4 sites of ablation at any one time point. It is enabled to treat vessels with diameter 3 to 8 millimeters. And in short, it provides more circumferential, more complete renal denervation, but again, also advancement into the distal branch vessels where the renal nerves are a more susceptible target to RF ablation energy. They're a more susceptible target to radiofrequency energy denervation. Recall that as a background for the Spiral Off Meds pivotal trial that I'll share with you in a few moments, 2 sham-controlled randomized feasibility studies were completed demonstrating the not only biologic proof of principle for renal denervation therapy, but equally, if not more important, the efficacy both in the absence and in the presence of prescription medications for hypertension. And specifically, in the off-meds experience where patients are washed off intentionally their antihypertensive medications for a transient period, their blood pressure is allowed to escalate. Renal denervation therapy was associated with a nearly 6 millimeter reduction in the 24-hour ambulatory blood pressure and a 10 millimeter reduction in the office systolic blood pressure, keeping in mind that most pharmaceutical drugs that are prescribed are approved on a 24-hour ambulatory blood pressure reduction of about 3 to 5 millimeters mercury. And similarly, in the on-meds population, we achieved 9 and nearly 10 millimeters reductions in the systolic blood pressure over 24 hours and in the office setting, respectively. Also, in this experience with renal denervation therapy, we've observed this, what we termed always-on effect. That is, in comparison to the control group, over a 24-hour period surveyed for blood pressure measurements, renal denervation therapy is associated with a consistent, persistent reduction in the blood pressure. And this has a special importance to those individuals who, for example, have nocturnal hypertension or early morning hypertension, conditions or phenotypes of blood pressure in which there is an even heightened risk of mortality or adverse consequences of end organ damage. What's equally important too is that we see this always-on effect, which is quite distinctive from the limitations of pharmaceutical therapies that have pharmacokinetic peaks and troughs and dosing regimens, and certainly it's distinctive from the limitations related to drug adherence. So with those successes and with that background, we embarked on an international spiral HTN off-meds pivotal trial. This was a study performed at 44 centers in Australia, North America, and in Europe, in which patients were with moderate uncontrolled hypertension in the absence of antihypertensive therapy were randomized to renal denervation or the sham control procedure. The study was performed as an a Bayesian adaptive trial design, meaning that we leveraged predicate data from the 80-patient spiral HTN off-meds pilot trial and combined it with a larger randomized cohort of 251 patients prospectively enrolled in the trial to create a larger patient population of 331 randomized patients who were evenly randomized to renal denervation or a sham control. The study also implemented an adaptive design in which the trial could be stopped if there was at least nearly 98% probability of superiority for both the ambulatory blood pressure over 24 hours being reduced with renal denervation, as well as the office systolic blood pressure at 3-month follow-up. And nearly 100% completeness of follow-up was achieved in the study population. Keep in mind that in renal denervation hypertension trials, these patients are not necessarily representative of those included in, for example, a drug-eluting stent trial. They're typically younger individuals. The prevalence of comorbidities such as diabetes is lower, but these are fairly hypertensive patients. Their average systolic blood pressure in the office setting exceeded 160 millimeters mercury. The average diastolic blood pressure approximated 100 millimeters mercury. And with regard to the renal denervation procedure, an average of nearly 47 ablations per patient was performed in both renal arteries as well as into the distal branches. And just as a note, this is at least 4 times the number of ablations that were performed in the initial Simplicity HTN3 trial, which did not demonstrate the efficacy of renal denervation therapy with a single point of contact catheter that was limited just to the main renal arteries alone. The trial met its primary endpoint. It was presented as a late-breaking trial at the ACC scientific sessions by my colleague and co-principal investigator, Michael Boehm, and simultaneously we published these data in the journal The Lancet. In short, the trial achieved effectively 100% probability of superiority for renal denervation therapy compared to the sham control to significantly reduce both 24-hour ambulatory blood pressure as well as the office systolic blood pressure at 3 months follow-up. And more specifically, we achieved an approximate 5 millimeter reduction in the 24-hour ambulatory systolic blood pressure and a slightly more than 9 millimeter reduction in the office systolic blood pressure at 3 months follow-up. These differences relative to the sham control were statistically significant, and we equally demonstrated significant reductions compared to the sham control group with regard to the diastolic blood pressure as well. What's also important is that these absolute reductions in this moderate uncontrolled hypertension patient population may not tell the full story, because the blood pressure reductions may be even greater over longer term follow-up that we've observed in other trials. And further, the differences relative to the sham control may be somewhat lessened or mitigated or muted simply because a greater number of patients, in fact, a significantly greater number of patients, 3 times as many patients in the sham control group, had to exit or escape from the trial protocol within the 3-month time period from randomization to the primary endpoint follow-up because of severe hypertension. And in fact, because of this, these patients most oftentimes did not have a 24-hour ambulatory blood pressure performed, and therefore they could not contribute to the trial results. And therefore, some of the very high blood pressures in the sham control group are not represented in these data. With regard to pre-specified subgroups, overall, the point estimates favored statistically, if not trended to favor, all subgroups with regard to renal denervation therapy versus the sham control group. And once again, now in the third sham-controlled randomized clinical trial that we've performed, we once again see this persistent always-on effect of renal denervation therapy, lowering blood pressure at all time points at 3 months compared with baseline. And this is a difference, of course, in the right-hand panel that is not observed in the sham control group at all. Also important is that renal denervation therapy proved to be safe. There were no device-related adverse events both at 1 month at the procedure nor at 3-month follow-up, and overall a very excellent safety profile with regard to preservation of renal function, with regard to any device-related consequences or procedural complications. These simply were not observed whatsoever. Importantly, that trial is also now completed, but has been paralleled by an ongoing, and now as we are re-engaging in clinical trials worldwide after the COVID illness that we hope to soon complete, it is complemented by an on-meds extension or companion trial. This is a large international trial in which patients with uncontrolled hypertension once again are randomized to renal denervation therapy versus the sham control. But unlike the pivotal trial data that I just shared with you, in which that was a drug washout regimen and patients were not treated with antihypertensive therapy, these patients have persistent uncontrolled hypertension despite the prescription of anywhere from 1 to up to 3 routinely prescribed antihypertensive drugs. And further, we'll be soon embarking on an exploratory pilot trial as well, termed the Spiral Distal study. This will be a study performed in Europe and in Australia and in the United States, in which we're performing renal denervation therapy with the spiral catheter exclusively in the distal segment of the main renal artery and in the very proximal segments of the first order branches. These are the areas where anatomically, again, there is a more approachable, susceptible target for renal denervation therapy given the approximate location of the efferent and afferent nerves to the renal artery branches. And we're exploring whether treatment at just these sites alone achieves similar magnitudes of reduction with what we might call more complete denervation in the earlier studies. So in summary, with regard to renal denervation therapy, renal denervation results in statistically significant but clinically meaningful reductions in blood pressure in an uncontrolled antihypertensive patient population compared to the sham control, but also in the absence and presence of commonly prescribed medications. And we observe this always-on effect, this persistent reduction in blood pressure throughout the day and nighttime periods. With RF ablation using the spiral catheter, we've observed no major safety events across these studies. And now there is an emergence of enthusiasm for renal denervation therapy, one step closer bringing this to routine clinical practice with the successes of the HTN pivotal off-meds trial, and soon to be completed the on-meds study as well. I'm going to transition then from the aspect of hypertension and renal denervation therapy then to percutaneous coronary revascularization and strategies with regard to abbreviated antiplatelet therapy, and specifically the increasing attention to high bleeding risk patients. Up to 40% of patients undergoing PCI we recognize worldwide have high bleeding risk characteristics. And this is relevant because the mortality after a major bleeding event is the same in magnitude as the mortality after a major ischemic event such as myocardial infarction. And increasingly, there's been a greater focus on shorter durations of dual antiplatelet therapy rather than longer durations or a lifetime commitment to dual antiplatelet therapy after drug-eluting stents based on the advancements in stent technology and the safety associated with them. And in fact, guidelines now recommend shorter durations of dual antiplatelet therapy, in some instances as short as 1 month. But regrettably, this has been largely based on consensus opinion or data with drug-eluting stents that have limited or no commercial availability. And so there's a need to better understand shorter durations of dual antiplatelet therapy with regard to both effectiveness and safety in high bleeding risk patients, but with current, contemporary, and commonly used drug-eluting stents. With regard to one of those stents, the Resolute Onyx stent, there has been a historical experience where durations as short as 1 month of dual antiplatelet therapy in less selected patient populations may do very well. And recently, we've completed the Onyx 1 international randomized clinical trial that was randomizing patients to the Resolute Onyx stent or the polymer-free drug-coated BioFreedom stent, which showed the non-inferiority of just 1 month of dual antiplatelet therapy. The Onyx 1 CLEAR study was an extension of the Onyx 1 randomized clinical trial. This was a study performed specifically in the United States and in Japan to extend that experience as a regulatory pivotal trial for the United States of 1 month dual antiplatelet therapy with the Resolute drug-eluting stent. It was a prospective single-arm trial because no randomized trial could be performed in the United States or Japan because no stent is currently approved for only 1 month of dual antiplatelet therapy in these geographies. But uniquely, the trial was statistically powered to evaluate the outcome of cardiac death and myocardial infarction, and it represents the largest combined survey of patients treated with a contemporary drug-eluting stent and yet treated with only 1 month of dual antiplatelet therapy. This trial was presented also as featured research at the American College of Cardiology meeting, and specifically over 700 patients in the United States and Japan were enrolled, treated with the Resolute drug-eluting stent and fulfilling high bleeding risk criteria. And these patients were combined with a select population from the randomized trial, the randomized Onyx 1 study of patients treated also with the Resolute drug-eluting stent, to evaluate the outcome of cardiac death and myocardial infarction between 1 and 12 months with just 1 month of dual antiplatelet therapy, and then a transition to single antiplatelet therapy. And specifically, we studied this 1 month strategy in high bleeding risk patients who were considered 1 month clear. And 1 month clear was defined as patients who were adherent for the 1 month of dual antiplatelet therapy with no significant interruptions and were free of ischemic events or any other event that would preclude stopping dual antiplatelet therapy at 1 month time point. So event-free patients at 1 month who were adherent to drug through 1 month. The bleeding risk criteria are represented in this figure. They range from being of advanced age to a requirement of oral anticoagulation or advanced kidney disease or liver disease or profound anemia or recent bleeding event. And as I've shared with you, patients were prescribed dual antiplatelet therapy at the investigator's preference for up to 1 month, and then after 1 month, the patients transitioned to a single antiplatelet agent. At the physician's discretion, it could be aspirin most commonly, or it could be the P2Y12 inhibitor. Altogether, then, we collected the outcomes of 1,506 patients with nearly 100% completeness of follow-up at 1 year. And just to remind us, too, that high bleeding risk criteria rarely occur in isolation. That is, the average number of bleeding criteria per patient was more than 1.6, meaning that nearly half of the study population met at least 2 of the high bleeding risk criteria. Most commonly, they were being of advanced age, or at least 75 years of age, or having the requirement of oral anticoagulation. But one can see too that anemia or the need for transfusions or renal failure or other high bleeding risk characteristics were fairly common. Also to share with you importantly is that these are patients who were relatively high risk with regard to clinical characteristics. In fact, nearly 40% of the study population was diabetic. Over a third of the patients had atrial fibrillation, and nearly half of the patients presented with an acute coronary syndrome. More specifically, roughly a quarter of the study population had presented with myocardial infarction, but again, were still treated with only 1 month of dual antiplatelet therapy. Also, the lesion characteristics were relatively complicated. Patients could be treated for bypass graft disease, for unprotected left main disease, for 2-stent bifurcations, for chronic total occlusions, and the average stent length was approximately 37 millimeters per patient. But despite the angiographic, the clinical, and the anatomic complexity, nevertheless, nearly 97% of the patients at 1 month transitioned from dual antiplatelet therapy to a single antiplatelet agent, and this was maintained through 1 year in 89% of the study population. And the trial met its primary endpoint, achieving a significantly lower event rate of cardiac death and MI between 1 month and 12 months of 7.0%, compared with a historical performance goal that was derived from previous studies of shortened dual antiplatelet therapy duration. Represented in Kaplan-Meier analysis too, we don't see, importantly, an escalation or an abrupt signal of increased events occurring after the cessation of dual antiplatelet therapy at 1 month. And we don't see a very high risk of any major adverse events such as myocardial infarction or stent thrombosis. In fact, despite the patient complexity, the stent thrombosis rate was 0.7% of definite probable events at 1 year, and the rates of myocardial infarction at 1 year were also less than 5%. So in summary, the Onyx 1 CLEAR trial extended the findings of the Onyx 1 global randomized trial in high bleeding risk patients now to the United States and Japan who were treated with only 1 month dual antiplatelet therapy. The trial met its primary endpoint, demonstrating favorable safety from 1 to 12 months, with stopping antiplatelet therapy after treatment with the Resolute drug-eluting stents with just 1 month of DAPT. And it also showed favorable efficacy, a TLR rate of only about 3.5% at 1 year as well. So altogether, these results, along with the large international randomized trial, would support the use of 1 month dual antiplatelet therapy for appropriately selected patients treated with a Resolute drug-eluting stent. And perhaps it'll be a discussion point for us later, but perhaps this is not something that may be a class effect, but maybe more specifically needed to be studied with individual drug-eluting stents. But I'll still focus on the issue for a few moments of shorter dual antiplatelet therapy with the Augustus trial design. The Augustus trial was a sub-study was also presented as a late-breaking trial at the ACC meeting and simultaneously published in the journal Circulation. Recall, Augustus was not a shortened dual antiplatelet trial in PCI, but it did evaluate in ACS and PCI patients who were treated with a P2Y12 inhibitor, a randomization to either apixaban, the direct oral anticoagulant, or a vitamin K antagonist, and as a secondary randomization, patients were randomized to both placebo or to aspirin. And importantly, in that trial, you may recall that although not statistically significant, there were higher adverse events in patients who did not receive dual antiplatelet therapy along with an oral anticoagulant within the first month of, for example, PCI. And specifically, stent thrombosis seemed to be nearly 2-fold higher in patients who were not on triple therapy, at least for the first month. And therefore, this analysis that was published in the journal Circulation was an evaluation of the risks and benefits of short-term dual antiplatelet therapy along with oral anticoagulation. And indeed, in this large trial of nearly 4,600 patients, when patients underwent PCI, for example, or presented with an acute coronary syndrome, just within the first 30 days, triple oral antithrombotic therapy, that is, for example, clopidogrel, aspirin, and an oral anticoagulant, was associated with approximate 1% higher risk of major bleeding complications. But on the other hand, it was associated of equal magnitude with an approximate 1% reduction in major ischemic events such as death, stroke, myocardial infarction, or stent thrombosis. On the other hand, after 30 days and through 6 months, major bleeding was considerably higher with triple oral antithrombotic therapy, and yet there was no additional benefit of continuing dual antiplatelet therapy with the oral anticoagulant in terms of reducing major ischemic events. And so altogether, these data would further reaffirm that for patients who have a requirement for oral anticoagulation after PCI, for example, those with atrial fibrillation, that perhaps the best combination is triple antiplatelet therapy for 1 month, but certainly no longer than 1 month therapy. And secondly, as another major trial presented at the ACC meeting, published simultaneously in the Journal of the American College of Cardiology, was yet another additional study looking at shorter durations of dual antiplatelet therapy from the Twilight study, but specifically in patients with complex anatomy or complex procedural characteristics. You'll recall from the Twilight study that over 9,000 patients were randomized to either ticagrelor and aspirin for 3 months, but then after 3 months were randomized to ticagrelor alone or continuing on ticagrelor and aspirin. In this trial, remember, this was not like the Onyx 1 Clear trial of a high bleeding risk, dedicated high bleeding risk trial, but there were certainly many clinical characteristics, some of which would pose a high bleeding risk. Patients with advanced age, with chronic kidney disease, but also patients, importantly, with ST elevation, myocardial infarction, or the need for chronic oral anticoagulation were excluded, and those patients, recall, were included in the Resolute Onyx 1 Clear trial. This particular analysis was dedicated toward looking at the benefits or risks of shortened dual antiplatelet therapy in patients undergoing complex PCI, meaning multivessel PCI, having a total stent length of greater than 60 millimeters, use of atherectomy, whether it's a chronic total occlusion, unprotected left main disease, or a bypass graft as an example. Most of the patients constituting the complex PCI cohort, which represented roughly a third of the study, were because of a stent length that was more than 60 millimeters. But also one can notice that multivessel PCI was quite common. Chronic total occlusions and bypass grafts and unprotected left main disease was also fairly represented in this clinical trial. And what's interesting in this Twilight complex analysis is that once again, when patients were continued over a longer term with dual antiplatelet therapy of aspirin and ticagrelor, bleeding rates, whether it was a complex or a less complex procedure, bleeding rates were considerably higher with long-term dual antiplatelet therapy compared with only 3 months of aspirin and ticagrelor followed by ticagrelor alone. But what's of a special interest is that for complex PCI patients, shortened dual antiplatelet therapy for only 3 months followed by ticagrelor alone was associated with a similar, statistically and numerically similar event rate of major ischemic events over 1 year follow-up, that is death, myocardial infarction, and stroke, compared with patients taking longer-term dual antiplatelet therapy. And therefore, for patients fulfilling these criteria, a 3-month strategy of aspirin and ticagrelor followed by ticagrelor alone seems to be safer and at least as effective as longer-term dual antiplatelet therapy, independent of the lesion and anatomic complexity. Finally, we'll transition out of antiplatelet therapy to another issue of complex PCI altogether. And this is regarding unprotected left main PCI and the pre-combat 10-year outcomes reported as a randomized trial of patients with unprotected left main disease randomized to either PCI or to bypass surgery. These data were presented by D.W. Park from the Asan Medical Center in Seoul, Korea, and simultaneously, and just recently published, that is, in the journal Circulation. Recall that the pre-combat study was a modest-sized randomized trial of 600 patients randomized to either PCI with the first-generation sirolimus-eluting cipher stent or to bypass surgery. But importantly, this study highlights some important findings with regard to the safety of long-term follow-up with regard to left main PCI. And specifically in this trial, the 10-year outcome of death of myocardial infarction, stroke, or ischemia-driven target vessel revascularization was statistically similar between the two groups of PCI versus bypass surgery, reassuring data. Now, importantly, the trial was perhaps underpowered for long-term follow-up. There's an approximate 5% difference, absolute difference between these two treatment strategies. But as I'll soon share with you, this difference was principally driven by a difference in repeat revascularization. Specifically, through 10 years of follow-up, the outcome of death, MI, or stroke was nearly identical over long-term follow-up between the two treatment strategies. And the difference was principally driven instead by a higher rate of repeat revascularization, consistent with what we've observed in previous randomized trials of PCI versus bypass surgery, favoring the bypass surgery cohort. That said, however, importantly, through 10 years of follow-up, once again, the rates of all-cause mortality through 10 years were nearly identical in this trial dedicated to unprotected left main revascularization strategies. And I'll also share with you then that these findings are also consonant with the left main cohort of the Syntaxis trial. Recall, recently presented within the past year, were the 10-year follow-up of the Syntax trial. And for the left main cohort, the rates of 10-year mortality were quite similar between those undergoing PCI and those undergoing bypass surgery. This has been in somewhat distinction to the 5-year results that we've recently published in the New England Journal of Medicine from the Excel trial, the largest trial randomizing patients with unprotected left main disease to either PCI or bypass surgery, totaling approximately 1,900 patients, in which we saw a differential effect or benefit over long-term follow-up between bypass surgery and PCI, such that overall through 5 years, we see no significant differences between PCI and bypass surgery, but we see a greater hazard in the first 2 to 3 years with bypass surgery and a higher risk over late-term follow-up, perhaps, albeit not significant, with PCI. Specifically, one issue that has raised controversy at 5-year follow-up was the observation of a significantly higher incidence of all-cause mortality. Now, importantly, cardiovascular mortality differs only by approximately 1%, and therefore there were no significant differences in the rates of cardiovascular mortality. Overall, through 5 years of follow-up, there were no significant differences in myocardial infarction as well. But there was a higher incidence of non-cardiovascular related deaths in the PCI group, contributing to a higher risk of all-cause death. And this raised a great deal of debate and concern in the media, especially raised by a cardiac surgeon investigator from the United Kingdom, that made quite a bit of news in the media with regard to allegations of improper record keeping in the trial, to inadequate or changing of definitions in the study, all of which I think has now been resolved and has proven not to be the case. But overall, just to share with you in the context of the pre-combat study, that this trial supports the findings that we've observed in larger surveys, in this instance, meta-analyses of randomized trials of PCI versus bypass surgery, in which in the subgroup of patients with left main disease, totaling nearly 4,500 patients, we see again nearly identical rates of overall mortality between PCI and bypass surgery. And further, when we update a meta-analysis of the dedicated left main PCI trials, and we now include the pre-combat 10-year data, we see that the point estimate is essentially at unity. That is, there is no significant difference favoring either PCI or bypass surgery for unprotected left main disease with regard to all-cause mortality. And finally, in the last few moments, with regard to a review of our trials from the ACC sessions, is that the ischemia trial was not presented as a late-breaking trial at the American College of Cardiology, but simultaneous with the ACC meeting, 3 separate trials from the ischemia study, including the main primary manuscript, were published in the New England Journal of Medicine. And importantly, a sub-study of the ischemia trial was, however, presented at the ACC sessions that I'll share with you in a moment. So recall that the ischemia trial initially enrolled over 8,500 patients with high-risk findings on stress testing with large areas of ischemia. Ultimately, however, most of these patients underwent coronary CT angiography per protocol prior to randomization. A number of these patients, despite the limitations of the non-invasive stress test, actually didn't have obstructive coronary disease. Some of them even had unprotected left main disease that was significant and were therefore excluded. But ultimately, slightly more than 5,100 patients were randomized to an invasive strategy combined with medical therapy or to medical therapy alone and no revascularization. Recall that in this recently published manuscript in this randomized trial, there were overall, through 5 years follow-up, no significant differences in the outcome of cardiovascular death or myocardial infarction at 5 years. However, there seemed to be a higher risk of adverse events in the early time period with PCI, but beyond 2 years of follow-up, the event rates seemed to diverge in favor of an invasive strategy that included mostly PCI, but about 25% of the patients in the study underwent bypass surgery. And specifically, that difference was driven early by the rates of periprocedural myocardial infarction, but there was also observed through long-term follow-up that spontaneous myocardial infarction seemed to be significantly lower, reduced by about 1/3 with revascularization. And these findings may be considered similar to the FAME-3 trial, in which, again, patients with hemodynamically significant disease had a higher risk of myocardial infarction if not treated with revascularization. As an important sub-study of the ischemia trial, presented at the American College of Cardiology meeting, and as of yet not published, however, was the analysis of myocardial infarction according to different definitions. The primary definition was by a periprocedural MI with PCI of a CKMB 5 times the upper limit of normal, and by surgery 10 times the upper limit of normal. And the secondary definitions involved the use of troponins rather than CKMB. But put simply, this analysis showed that spontaneous myocardial infarction was significantly reduced with successful revascularization, whether it occurred by PCI or by surgery, compared with medical therapy alone in the ischemia trial. What's also relevant, and we have a manuscript coming from the Excel trial showing somewhat similar themed results, is that the risks of procedural myocardial infarction had no impact whatsoever on all-cause mortality, and perhaps a modest, if not modestly significant effect on the occurrence of cardiovascular death. But the greatest predictor of mortality over follow-up, whether it was all-cause mortality or cardiovascular mortality, was the occurrence of spontaneous myocardial infarction. So again, we have the opportunity in the ischemia trial to reduce spontaneous myocardial infarction with successful revascularization. And these findings fall against the context of a significant improvement in quality of life for these very symptomatic patients. Recall that in the ischemia trial, the benefits of revascularization in improving patient self-reported angina, in this instance measured by the Seattle Angina Questionnaire, were sustained through 3 years of follow-up. And in fact, the number needed to treat to improve quality of life for patients was extremely small with revascularization, the number needed to treat only being 3 patients. So we've ranged from renal denervation therapy, device-based therapies for the treatment of hypertension, to antiplatelet strategies and percutaneous revascularization, to complex PCI, specifically with unprotected left main disease. And I hope this this provides you what I've shared with you, an overview of the important trials from the ACC 2020 meeting. So thank you again for having me, and I'll transition back to our panelists.
Thank you very much, David. Did a great job, excellent presentation, great slides, and you went over them in a good way. So from now we'll go to our panelist. I think it's the question from my side is easy. What do you think about this studies? Is there any comment about it? Does it change your practice or not? So anyone would like to start with this?
I think first of all, thank you very much, David. It's a very nice presentation. Sounds like a very nice music to my ears. As I'm listening to you, I'm enjoying each slide that you presented. So thank you very much. This is as always. So that's always the case with you. So I think renal denervation, I think when we try to summarize, renal denervation is, we learned over the years with renal denervation that it's patient selection, it's the denervation process and how we do the denervation and how many points that we need to denervate. And what's more important is our prediction. I think we actually predicted too much from this therapy, that we were expecting a 30 millimeter reduction or whatever. And we realized that we have to put it in its context. So we have to understand this is a modality that will grow and we will learn more. And it's just, it's in early stages. So as we see now, the result of the renal denervation off-med trial and the on-med trial, it tells us this therapy works. And we know because we treated patients, we've been following, but we know that how to select patients, how to do the denervation, how many points of denervation, where exactly you do the denervation, and what's your expectation. Put it to the patient, tell the patient the reality. So both sides will be actually happy at the end of the day. So renal denervation is a therapy that is back, and I think it is back to stay. But I think we will learn more as new catheters, new change in technology will be evolving. When it comes to the lift main the dual antiplatelet therapy and the short duration, I think we learned that Onyx is superior than any other stents when it comes to short therapy from the Onyx trial. But what we also learned that we are not really evaluating patients enough for the risk of bleeding. Maybe we're not doing enough screening patients for bleeding, because as you look, I think our algorithm has to be incorporated very well. When we assess how long you're going to give therapy, we have to incorporate very well the risk of bleeding in our decision making to avoid what we can prevent. Because as I see in the practice, at least in our country here, there is no proper screening for what's the risk.
You have 1 minute, Muhammad, so you can be able to go to others.
Yeah, sure. That's I think the thing. I mean, the last thing I would say, for the sake of time, I think aspirin is not anymore our preferred kit. It's ticagrelor, and we are moving away from aspirin, and we're replacing it with a new kit called ticagrelor. So I think that's what I see over the trials in the last couple of years. And aspirin is losing its seat and being given to another drug. We can continue discussing, but I will give the space to the others to talk. Thank you.
Dr. Hani or Dr. Abdullah would like to.
Sure.
Hani, Dr. Hani, you may unmute your mic.
Yes. Can you hear me?
Yes.
For me, I mean, I love the presentation. And the nice impact of it is a lot of it is actually practice changing. For me, one of the major practice changing pieces of knowledge is the Onyx 1 data and the Onyx 1 Clear data, because the majority of patients who may be high bleeding risk are also patients that you might discover that retrospectively after you do the procedure. I mean, I don't think that many people will go to a 75-year-old patient and specifically stop the dual antiplatelet after 1 month. But to actually know that if you have to do that, you can do it safely is a game changer. I mean, for me, to be able to know that the stent that I'm putting this particular patient, if I have to stop the dual antiplatelet therapy in 30 days, I have data to do this comfortably, is a game changer. And indeed, I mean, I think that recently the Onyx actually received the CE mark for this indication of a dual antiplatelet therapy for 1 month, which is the only drug-eluting stent that you can, that has this CE mark. because we had that before with the comparator, but as you know, it's not a drug-eluting stent. It's a drug-coated stent, so it has a high rate of restenosis. But the Onyx, with its deliverability and the fact that, that you can now use a dual antiplatelet therapy for 1 month, on a personal level, makes it difficult for me to use other drug-eluting stents, quite honestly. As far as the other papers, you know, what the ischemia trial proving for the first time ever that what we claimed as interventional cardiologists to do, which is to prevent MIs, is actually true. And what we have been accused of, every time they told you that patients with 90% stenosis in their LADs had the angioplasty thinking that it's going to stop them having a heart attack. Well, yes. You know what? This has been proved in ischemia. A trial which was initially assumed to be negative for intervention turned out to be excellent. And I really, really agree with the fact that stable patients with no angina should have a first medical treatment attempt. I mean, that's a great thing to do. I mean, you don't want to PCI everybody, but at least those patients with significant ischemia who receive a stent, you can really now have the proof that downstream that you can actually prevent a downstream MI with all its sequelae. So this has been incredible. My last point, of course, is on the renal denervation. I do run a hypertension clinic, and one of the big disappointments in my life was Simplicity 3, because you know, I could see the shortcomings of the trial. So having the spiral off med and then the on meds is bringing back renal denervation to mainstream is something really, really looking forward to. And I thank the Gulf Intervention Society. I thank you, Mr. Chairman, and definitely I thank David for an amazing presentation.
Excellent comment. Abdullah?
Yeah, Dr. Fawaz, excellent selection of our great speaker, David. I think I concur. Everyone says the compliments of these studies, I think, relevant and refining our, I think, practice. Unmet needs for hypertension is well known. We have 1 in 5 in our Middle East have hypertension. Adherence is very bad. Having something like this instead of medication, I think, would be great. I can join, you know, the Onyx, Twilight, and the other studies together. It all talks about the bleeding. Bleeding is a cause mortality. So to have a stent which, you know, reduce your medication to 1 month or 3 months, like Twilight says, and to go with a medication like ticagrelor or something like clopidogrel, in the context of that kind of a stent, without you know, having problem with this, you know, in terms of mortality and bleeding with a complex PCI as described by Twilight, I think it's a great, and I think will change my practice. And in terms of Recombat XL, I think tells us that the left main PCI is safe, comparable to you know, both PCI and CABG, comparable in terms of mortality, and everyone got their advantage. You know, early advantage PCI, late advantage with the CABG. But at the end of the day, it depends, you know, how depends on the operator skills and the volume. So it's like excellent if you do a PCI properly, and it could be a noble for CABG if you done properly. And I think to finish with ischemia, I think ischemia for us in the COVID time, I think is great news because medication work and it's, you know, comparable to the intervention if it's done properly. And I think quality of life improves, especially the angina frequency if, you know, if we can intervene in the right patients. Thank you very much.
Excellent, Dr. Shahab. So I'll go back to Dr. Kansari and we'll go over our balance to this question. In these trials, did it change our practice? Is there any point that you want to deliver to our audience that this is something new, our practice should be changed after this?
No, thank you. And thanks to everyone's comments so far too. Very briefly, I'll just add that certainly the promise of renal denervation, I think Mohammed said that it's here and it's here to stay. And I completely agree with that. I think we're one step to getting that as a therapy for routine clinical practice. And what Mohammed highlighted too, I think is the key point, is that the expectations with regard to blood pressure. And keep in mind, though, that in these more contemporary trials, we're enrolling in these trials moderate, not severe uncontrolled hypertension, but moderate uncontrolled hypertension. And with more severe, the higher the level of hypertension, the greater reductions in blood pressure we do observe. And that occurs with both renal denervation therapy and with medications. Now, it's been contested, is that statistical regression to the mean, or is it that we simply observe a greater treatment effect with more severe hypertension? And I think this is an issue to be debated, but it could be that we do see greater reductions in patients with more severe levels of hypertension. But nevertheless, I think Mohammed's comments are very appropriate, that we know that right now this reduction appears to be similar to that of at least a single antihypertensive pharmaceutical agent. The second, and it's very safe too, and it's always on, unlike medications that are required for the patients to take it. And we know that 40% of the patients aren't taking their medicine in our clinical studies anyway. The only other point I'll make too, that in terms of practice changing results, our practice hasn't changed from the Excel trial with left main disease. My center was the world's leading enrolling center for unprotected left main disease in the Excel trial, and that remains a very common practice for us. But to Dr. Hani's comments about shortened dual antiplatelet therapy, I think that the Onyx data with Resolute really is a practice-changing step for us, because it highlights, to Hani's point, the safety if you have to stop dual antiplatelet therapy at 1 month. The message from that trial should not be everybody who has high bleeding risk needs to stop at 1 month. That's not the case. But if you do have to stop, or if you know that this is someone who's going to have upcoming surgery or really poses a high bleeding risk, I think we can feel very reassured from this large data set of the safety of, with specific though to Resolute drug-eluting, to the Resolute stent, of stopping dual antiplatelet therapy at 1 month.
Excellent. Dr. Kurdi, anything change your practice after we hear all of these trials? And you didn't comment about the ischemia trial. If you have.
I think the ischemia trial is definitely showed us that medical therapy is definitely an option. But what we learned as well, that if you do intervene, you are preventing future events. If you do screen, for example, CT and testing these patients earlier. So I can see that now I may use more CT scan testing and discovering patients who actually could have future events. So I think there are multiple messages that came from the ischemia trial. But yes, doing intervention protect down the road. It may not protect earlier, and medical therapy works earlier. I don't think ischemia will be changing my practice that much. I still believe intervention and doing intervention and risk stratifying your patients will be the way to go. And you're preventing something down the road. You have always to tailor your practice based on your system. And in our system, I'm afraid that patient will disappear and I will not see him. So I may intervene earlier than just leave him alone on medical therapy. That's regarding the ischemia trial.
Any of this study change your practice, Mohammed, in 1 minute?
I think the Onyx give me more comfort.
Okay.
The August trial tell me that again we're learning more that aspirin is the one that we should remove if we're worried about bleeding, and we keep the combination of the anticoagulant plus the ticagrelor. The left main PCI, if Taxus and Cypher were the stent and they're still showing comparable to surgery, then I think our stents are doing very well.
Excellent. Dr. Hani?
Dr. Moteri, there are two questions from the audience, if I may read them very quickly. One is from Dr. Mohammed El-Kapsi to all panelists and to David. In regard to ischemia trial, is it applicable for diabetic patient who has multi-vessel disease and not complaining of chest pain? Yes. I mean, those patients were not excluded from the ischemia trial, is my answer. And if your patient is asymptomatic, you might want to know how ischemic they are, at least. David?
Yeah, so I would say that that's a great question, and certainly the ischemia trial enrolled diabetic patients, as I recall, with multi-vessel disease certainly weren't excluded from the trial, and symptoms were not necessarily an exclusion either. Some of the patients, a significant proportion of the patients did not have symptoms, and so such a patient could be enrolled in the ischemia trial, and the results are, as we know. I think we'll learn more about subgroups like this of patients with multi-vessel disease, patients who are asymptomatic, patients with multi-vessel disease or proximal LAD disease, as more subgroup studies get published from this and presented from this database.
Okay. If you go to the questions and answers, there are 7 questions. Most of them are, 3 of them are on aspirin being taken off.
Hani, if you allow me, yeah. We'll go over them in a second. Just for 1 minute, tell me what things change your practice in these studies. Then Abdullah will say, then we'll go over question in the last 4 minutes.
Thank you very much, Fawaz. I'm sorry. I actually contacted Medtronic, and I want to go back to performing renal denervation on my indicated patients. The data which came out is enough for me. I don't need to, for a guideline change. The majority of the patients are unable to comply with the extensive pill regimens and are not controlled. The hypertension control in Egypt is a dismal 8%. We have our own data from the Delta C project. So I would like to start renal denervating patients now that we know how to do it. And I'm pleased to do that. And that for me is a big change.
Perfect. Abdullah, in 1 minute, then we'll go over question. Dr. Shihab?
Yeah. Thank you, Fawaz. I'm just saying, the ischemia trial, no doubt, is very relevant to our practice, optimizing the medication, and then use the intervention on those who are, having angina. Ischemia is not really giving us the answer. Although the study says it's excluding left main, I don't know if you've seen the latest from the Sky. They looked at the CT, excluded because of CT. The intermediate CT left main on angiography looked really severe. And those patients might benefit if they have symptoms on long term. But again, don't forget the procedures might cause problem. Twilight study and the Onyx study, of course, tells me I try to choose the monotherapy and try to be as early as possible, and that I've been practicing actually. Excellent.
David, there's a question here that said, if you have a left main stent, did you just stop aspirin after 1 month or keep him on ticagrelor alone?
So we had in the Onyx experience patients who did undergo unprotected left main PCI. So we have but it's a very small number of patients with regard to the safety of it. I agree with Mohammed earlier, though, in his comments about long-term antiplatelet therapy as a single agent with ticagrelor, especially based on the Twilight results. I think they're fairly compelling. That if you did stop dual antiplatelet therapy, my preference would be to go with ticagrelor alone. The issue for us in the United States is that ticagrelor is an expensive medicine for many people, and so the affordability is probably the biggest rate limiting step.
Good. Another question, say how do you explain the difference in outcome of RDN clinical study in the initial negative?
Yeah. Thanks, Basil, for that question too. Well, if we had much greater time, I would help explain that. But let me just very briefly say that, number one, we learned how we conducted trials in the space of hypertension is very different than what we initially expected. We know that when patients and prescribers change their behavior, are not fixed on a prescribed regimen, and drug adherence is variable and not tested, and prescribers are changing medicines throughout the course of the study, it really confounds the result. We secondly relied on the office blood pressure and not the ambulatory blood pressure, which was an error because of the variability in the office systolic blood pressure. And then finally, we changed how we do the procedure. We changed to the spiral technology that enables greater circumferential ablation for more complete ablation. And we also learned that if we extend RF ablation into the distal branches, we achieve greater reductions in norepinephrine spillover and a more effective denervation. And so it's changing the practice, changing how we do trials, how we define endpoints in trials, and trial execution.
Great. Last question, an AFib patient coming with ACS, what is your best triple therapy and for how long?
Yeah, so I think here is perhaps more insight from the ACC presentations that we shared from the Augustus study, that if it's an ACS patient who does or does not undergo PCI and requires oral anticoagulation, the best is low-dose aspirin combined with clopidogrel. Most statements would favor clopidogrel over ticagrelor or prasugrel as part of triple antiplatelet therapy, and then transitioning the patient to clopidogrel and the oral anticoagulant after 1 month and stopping the aspirin.
Excellent. I think it's reaching our time. I will kindly ask everybody to say 30 second final messages and thoughts. So we'll start with you, David.
Well, first of all, I'm grateful for being part of this program, and I want to say that I'm very envious of so many of my colleagues and panelists who have such beautiful backgrounds of the pyramids and beautiful cities that I need to come visit you sometime. That's my main statement.
Our pleasure. Our pleasure.
Thank you. My other main statement, though, is just that I think there's greater attention to shortened dual antiplatelet therapy in the high bleeding risk patient. I think a series of studies show that whether it's complex disease or not, that shorter durations of dual antiplatelet therapy are very effective and safe for these patients. I think we've seen reassuring data with regard to unprotected left main disease over long-term follow-up that should continue, should encourage us to continue the performance of this procedure. And finally, we've discussed extensively the promise of renal denervation.
Great. Dr. Kurdi?
First of all, I'd like to extend the invitation to Dr. David to visit Riyadh. We will reserve, David, this is we call Shamar and Agal, so we'll reserve one for you when you join us. So we will see how you look with the Saudi dress. So yeah, if we talk about today, I think it's important that we understand, as we said, renal denervation is really a therapy for hypertension. We have to focus on hypertension. We've been ignoring hypertension for a long number of years, not doing proper therapy. I think it's time to focus on really on these patients and initiate the proper programs of treating hypertension and following them up. I think the issue of the antiplatelet, as we said, now we have the evidence that this is safe, and we have to think of shortening the dual antiplatelet therapy. So thanks to Medtronic with their Onyx stent, and the rest we talked about. So I would like to thank you, everybody. Thanks to the GIS for this opportunity, and thank you yourself, Dr. Fawaz, for this opportunity.
Thank you very much. Dr. Hani?
Thank you very much. Again, this online meeting organized and executed by the Gulf Intervention Society is proof that we are fighting to keep the science going and to communicate and I'm so grateful for everybody here and for the attendees and for David Kanzari, who's taking time off from Atlanta in the middle of the COVID epidemic hitting. And we are going to win, you know, but, you know, hopefully with the most minimal losses. And actually 2 days ago, I sneaked at 6 o'clock in the morning, just after the curfew was lifted. And I did go to the pyramids, and I sat there and I meditated and I just looked at them and thought of how many plagues and epidemics and wars they have seen, and humanity in the end prevailed. So thank you, and this was an amazing evening.
Thank you very much, Dr. Hani. Dr. Abdullah?
It was a great, event as always. MashaAllah, it did greatly, and the panelists excellent input. And I really echo what all said. And really, I want to say just stay safe and healthy until next time.
Thank you very much. So I'd like to thank our speaker, Dr. David Kanzari, our panelists from Egypt, Saudi Arabia, and United Arab Emirates. Thank you very much for our audience. Thank you very much for Medtronic for the usual collaboration and sponsoring this webinar. Stay tuned with the GIS. We'll have a lot of activity for you in near future. Our next going to be a workshop, 2 days, led by Dr. Mohammed Kurdi about RDN. So thank you very much. Have a good night. It was a great time with you.
Thank you.